Hello, everybody. Welcome to today's session of our critical care webinars under the Forum Young India Intensivist. So today we have a very special speaker, Professor Stefan Acosta. Sir is a luminary in the field of acute mesenteric ischemia, and his work has contributed greatly to our understanding of this disease, which is has a very grave prognosis by and large amongst many other diseases. So just to briefly introduce Sir. Sir is Professor of Vascular Surgery at Department of Clinical Sciences, Lund University, and Senior Consultant, Department of Cardiothoracic and Vascular Surgery at Skåne University Hospital, Sweden. Sir is also the past member of the Executive Committee of the World Society of Abdominal Compartment Syndrome. Sir is also the past member of the Writing Committee of the Guidelines of the Diseases of Mesenteric Arteries and Veins for the European Society of Vascular Surgery. So it'll be really interesting to hear from Professor Acosta about acute mesenteric ischemia, a disease which has often a fatal prognosis. So over to you, sir. Thank you for sparing your time and joining us.
So thank you very much for your kind introduction. Well, I have been in this field for decades, so I have been following it closely, and I will give you now an overview of the field, of the current standings. So I will see if this is possible for me to share.
Yes, we can see your screen, sir.
No. You can see this slide now?
Yes, sir, yes.
Yeah. So acute mesenteric ischemia may look like this. So when you see such features after an explorative laparotomy, you will be concerned. So when you see this, you have to ask yourself, is this because of an occluding thromboembolic clot in the mesenteric arterial system, the arteria mesenteric superior artery? Or is it due to a non-occlusive mesenteric ischemia? So if there has been no computed tomography angiography prior to this finding, you have to go and explore the superior mesenteric artery and see whether it is open or not. Then you have to call the vascular surgeon really to perform this surgical maneuver. Otherwise, if there is computed tomography angiography performed and you are surprised at laparotomy and find this, you have to go back and check and scrutinize the images to scrutinize to see whether there is an occluding clot or not. Because if there is an occluding clot, you have to go ahead, call the vascular surgeon, and proceed with this intestinal revascularization procedure. If not, this is a non-occlusive mesenteric ischemia, and you have to go ahead using another tactics, another strategy, which we will talk about a little bit later. Here's another feature of acute mesenteric ischemia. It is mesenteric venous thrombosis. It's about 15% of patients with acute mesenteric ischemia will have this. And this is often limited part of segment, often the small bowel. And as you can see here, you have dilated intestines. And you can see the mesenteric is thickened. And this is because there is comprised venous outflow obstruction. And you can see the most reddish part, that is transmural ischemia. And well, after you have done a bowel resection of this segment, this patient should be on anticoagulation therapy. And most of these patients, if they are treated in time, they will have a favorable prognosis as opposed to those with arterial mesenteric occlusion, which have a more dismal prognosis. So when we look at the epidemiology of this disease, 2/3 of patients with acute mesenteric ischemia will have occlusion of the superior mesenteric artery. 15% will have non-occlusive mesenteric ischemia, according to this study. But those patients here in this study, they all have fatal non-occlusive mesenteric ischemia with transmural infarction. So the whole picture is not clear because there are many more patients actually with non-occlusive mesenteric ischemia that has non-transmural mesenteric ischemia. And about 16% will have mesenteric venous thrombosis. And there will always be a little group that is indeterminate because we don't really know if there was an occluding event or not. Based on this autopsy study, that in a population in Malmö, where I practice, we had an autopsy rate of 87% in the 70s. So we have a good grip of the natural history of this disease. So what has happened? We have looked into this panorama, and the incidence of acute mesenteric ischemia has been fallen, maybe because we don't perform so much autopsy, but we don't really believe that. We believe that we are now diagnosing these conditions more early, and we perform a lot of CT angiography. So we believe that the incidence has going down in this population, maybe also because of better medication of against atherosclerosis and against embolism. And also because of people in Sweden generally are smoking less. So we believe that the incidence is going down. And also we are much better in the treatment of patients with atrial fibrillation. We are more aggressive with the medication. So we see less patients with, for instance, acute occlusion of the superior mesenteric artery. But what we can see from this study is that a greater proportion now has been diagnosed with non-occlusive mesenteric ischemia. And that is because we perform a lot of CT angiographies. Most patients are diagnosed nowadays here in this country with computer tomography angiography. So what can be learned from these large studies based on autopsy findings here in Sweden about acute mesenteric ischemia and about acute occlusion of the superior mesenteric artery? Well, what we know is that this disease is extensive. So 50% of patients will have an infarction of the jejunum, the ileum, and the colon. So, with other words, they need intestinal revascularization to survive, because you cannot only go in and resect all the dead bowel, because you will leave the patients with short bowel if they survive, and they will have a poor prognosis anyway with the short bowel. So you have to think intestinal revascularization, and you think to have you have to think about early diagnosis and treatment of these patients to save the bowel and save the patient's life. So in this picture, we have those patients with embolism. There were 122 patients with embolism, and we know that 2/3 of patients with an embolic occlusion to the superior mesenteric artery, they have embolism to another segmental artery. That means, for instance, the renal artery or the celiac trunk or the cerebral infarction or leg or to an arm. So this means that patient that arrives with acute abdomen and has a pale arm or a cerebral vascular incident, you have to be very suspicious that this patient has, in fact, an acute mesenteric ischemia. And if possible, perform an urgent computed tomography angiography if this is available. So we recently performed an international study in collaboration with 32 hospitals around the world called the Amesi Study. It has recently been published. This is a study where we collected data on clinical and laboratory data on patients with acute mesenteric ischemia. And actually, there were 2 centers from India participating. This was one hospital in New Delhi, and there was one hospital in Lucknow. I don't know if I pronounce this city correct, but anyway, I think you understand.
Yes, so the hospital from Delhi was Maulana Azad and from Lucknow SGPGI, sir.
Yes, there was two hospitals.
Yes.
So good. And well, they were on suspected or confirmed acute mesenteric ischemia. So we did sub-study, and there were 231 patients with acute occlusion of the superior mesenteric artery, and we had 287 patients, control patients, that were suspected of having acute mesenteric ischemia but didn't. They had other disease, other acute abdomen. So they were a perfect control group to those patients that had acute mesenteric ischemia. And what we found was patients that were currently smoking, patients that had hypertension, they were more likely to suffer from acute occlusion of the superior mesenteric artery. If you had those patients had also more elevated white blood cell count, and those patients had also more higher frequency of bowel emptying, that is vomitus or diarrhea. Well, this is what we found. These are markers of association with diagnosis, but this, as you know, it's not very specific. For instance, white blood cell count is not very specific because many diseases has elevated white blood cell count. So we need better biomarkers, and this has been a topic of investigation for decades. And I will come to that a little bit later on, that we are hopefully advancing in that field. What about lactate? This is a favorite biomarker that is used in the intensive care unit. And I'm sure you use it regularly as well. And well, we had the patients with acute superior mesenteric artery occlusion, and we had a control. And there was actually no difference in lactate levels between those with and those without acute superior mesenteric artery occlusion until 0 to 12 hours before diagnosis. That is very late in the process until the patients were diagnosed. Then the lactate become higher in patients with acute superior mesenteric artery occlusion. But that is, well, it can be used. I mean, you follow the trend, but it is a very late marker for this disease, and we would like to get a grip of those patients much more early so that we can intervene in time and have a more favorable prognosis. When we looked at the subgroup in patients with an embolic occlusion, we did find that patients with atrial fibrillation had an increased risk of having acute superior mesenteric artery occlusion. And so a patient with an acute abdomen and atrial fibrillation, it may be anticoagulated, it may be not. Some of those are poorly anticoagulated. This should raise the suspicion of, can this be acute mesenteric ischemia? And this is mainly of use for those at the emergency department. So there are two ongoing prospective studies. One is called the TACTIC study. It is based on several centers in the Netherlands and Belgium, and they have patients with suspicion of acute mesenteric ischemia, and they intend to include 60 patients with acute mesenteric ischemia and 60 patients without, but very a control group that is very well selected for those patients. And the results are, I think it will come up late this year, actually. They have said they are finished in including patients. And they study biomarkers that reflect the intestinal wall, the mucosa, and also more the muscular layer of the intestines. So it reflects more transmural intestinal ischemia. And so we have a study that is about to start in Europe, and it's called the Bpalmy Study. And this as well are on patients that are suspicion of acute mesenteric ischemia. We intend to include 250 patients, and hopefully there will be half patients with acute mesenteric ischemia and half without. So these are our studies that are ongoing, and these studies will also have biobanking, and there will be plasma samples that will be saved for future studies and future arising biomarkers coming up. So not very easy study to perform, but and it requires a firm leadership, but this is ongoing and it will happen. So acute mesenteric ischemia of arterial origin. Here are some recommendations from the European Society of Vascular Surgery. So if you have a CT available, you should, in these patients with suspected acute mesenteric ischemia, perform a triphasic CTA. That is a CT without contrast, a CT performed in the arterial phase, a CT performed in the venous phase, in the parenchymal phase, if it's possible, with short slides, 1 meter slides, and then you're able to perform reconstruction of these CTs. And also, you should not be afraid of performing this CT with intravenous contrast if the patient has elevated creatinine, because many of these patients will have. They will be dehydrated, they will have been vomiting, they will have raised this creatinine level, but it's only dehydration. So they don't have a permanent renal failure. So you should take responsibility of these patients. Sometimes the radiologist has opinions, but I think you should go ahead, and you have the guidelines with you to go ahead and perform these CTs. So back to our patients. This is the patients with extensive mesenteric ischemia of arterial origin. And as you can see, the intestines are dilated more in the distal end than the proximal, and it's bluish discoloration. So this requires, at this point, collaboration between surgeons and vascular surgeons and anesthetists, of course. So what was done in this patient? Well, we went to explore the superior mesenteric artery, and you can see the retractor here on the right side holding up the column transversum. Here you have the main stem, and here you have some branches that has been clamped, and here you have vessel loops, and there you have an arteriotomy performed, and there you insert your balloon embolectomy catheter, and you perform an embolectomy. And I think that is the most common vascular procedure for acute mesenteric ischemia today at the emergency setting. And the easiest to perform. It's not an easy operation, but it is the most common and easiest. And if you have vascular training, you should be able to perform it. So afterwards, you close the arteriotomy, you release the clamps, and you have to do some kind of completion control of your vascular procedure. So in this case, we perform the transit time flow measurements. That is a probe around the vessel, and you can measure the flow going through the vessel. So here in this case, it was 218 millimeters per minute, and that is okay flow. Prior to that, it was 0. So, and you can see the irregular shapes of these pulse waves is because the patient had atrial fibrillation. So the flow through the superior mesenteric artery should be somewhere between 200 and 800 milliliters per minute. Just as so you know what kind of flow. If after revascularization, if there is only a flow of 20 or 30 milliliters per minute, something is wrong, and you have to check. You have to often go in again, redo the embolectomy, or do an angiography. Something else is required by you as a vascular surgeon. So here is the intestines afterwards. After the embolectomy, you can see some of the proximal parts of the small bowel has recovered. Some has not. And you take a half minute of break after this embolectomy, and then you go back and see that some of these bluish dilated bowels are not likely to recover. You perform the bowel resection, but you do not perform anastomosis at this point. The anastomosis are performed at the second look, where you are sure that the bowel ends will survive, and you can perform your bowel anastomosis in a secure place where the bowels are well perfused. So here you can see the small bowels going into this large bowels, and here you have the side-to-side anastomosis performed, and this patient survived, and without no short bowel syndrome. And of course, this patient had to have anticoagulation therapy closely monitored throughout his life. So vascular surgeons can do a lot of things with these patients if we get them in time. So, for instance, we have these patients with, this is a CT, and there is a virtual rendered imaging, and you can see some of the aorta, and you can see the superior mesenteric artery. Actually, this is part of the celiac trunk, supplying the splenic artery. And actually, here's an anomaly, and there's the superior mesenteric artery going to the hepatic artery. And here is the superior mesenteric artery, and you can see that here is an occluding embolic clot. So we went ahead. This patient had no peritonitis, And here she is at the hybrid room. Well, there is an anesthetist present, but we perform this operation in local anesthesia. So here we performed the angiography. It showed the same thing as the CT angiography. In the main stem, you have an embolic clot here, but additionally, the angiography was able to see some other features of embolism. So there are fragmented embolisms in the colica media. Here's the colica media, here is the colica dextra, here's the ileocolic artery. So this patient, we were able to, from the groin, suck, aspirate the embolus out and expel it here, as you can see on these dressings. So we can repeat that. We can go back and check with angiography and see that the main stem is cleared. But there are still issues with colica media and colica dextra. We were not able to aspirate those clots. So we put in angiography catheter, and we performed thrombolysis. The patient was at the intensive care unit. We closely monitored, received thrombolysis for 10 hours, actually 1 milligram per hour, 10 milligrams. That is very little, 10 milligrams. It's not very much, actually. So you can see that the colica media has reopened, and the colica ileocolic is opened. The colica dextra is still occluded, but it does not really matter because we have collateral systems supplying the right colon enough so that no bowel resection was needed. So this is examples of how you can treat these patients both with open vascular surgery and endovascular surgery in patients with occlusion of the mesenteric arterial system. If we get them on time, we can do a lot of different things with them. But unfortunately, I know globally they are arriving late, they are diagnosed late, they receive treatment late, and the majority of patients will die. Some of them may be rescued with bowel resection and some will not. So this was the patient at her home, no bowel resection, full anticoagulation, and she's doing well. Here's another patient at explorative laparotomy. This does not look very good. So we have an extensive small bowel ischemia. And this was actually a case that was overlooked by the radiologist. So we went back and scrutinized the CT images, and we found occlusion of the superior mesenteric artery. So the patients were treated. We went ahead and got the C-arm, and then we performed angiography of the superior mesenteric artery, recanalized the artery, and put a stent there. And then afterwards, immediately, the intestines were more happy. So were perfused, and we were able to save all the bowel, and no bowel resection was needed. So here she is at discharge. She should, of course, you should not forget to, I mean, these patients, this was an atherosclerotic disease. The patient should stop smoking, should be on antiplatelet therapy, and should receive statins. So this was a good case. It was rather late, but anyway, it was salvageable. Now, Non-occlusive mesenteric ischemia. I know that this is a very important topic for intensivists around the world. And this is a difficult topic. How can you know that the patient in intensive care unit suffers from non-occlusive mesenteric ischemia? This question arises all the time, every day around the world in every intensive care unit, I think. So when a patient is not doing well, can this be due to non-occlusive mesenteric ischemia? Is it possible? So a lot of research is ongoing right now, and that is driven actually by your own people, by intensivists, because we need biomarkers that reflects if the patient has non-occlusive mesenteric ischemia. The small bowel is long, and the colon as well, and this is many meters of area that has to somehow be better diagnosed in the future. I'm sure this will pop up. So here's a patient that had an acute myocardial infarction. Afterwards, he developed peritonitis. And this was because of low flow, a low cardiac output. And his large intestines were damaged. They got hyperperfused. The patient developed, as you can see, a transmural infarction of the sigmoid colon. So this is the sigmoid colon, this is the colon transverse. So we performed the bowel section of the colon. And as you can see, you should always think that the area of the mucosa is more damaged, more infarcted than the serosa side in patients with mesenteric ischemia, because the ischemia goes from inside mucosa to outside of the serosa. So what the surgeon sees at the open abdomen, it's always limited spectrum of actually what is of the whole disease. So there is a consensus definition of what is non-occlusive mesenteric ischemia, and I will read this up for you. NOMI is defined as a hyperperfusion syndrome that occurs when severe ischemia of the intestines develops, despite the mesenteric arteries being patent. It is caused by either mesenteric vasoconstriction, secondary to conditions such as heart failure, vasoconstrictive medication, and hypovolemia, or by increased intra-abdominal pressure. So which are the scenarios that usually are suffered from non-occlusive mesenteric ischemia? Well, the patients with severe cardiac failure needing massive inotropic support on an intra-aortic balloon pump device to survive. The postoperative patients after cardiac surgery. We have the patient with septic shock, hypovolemia after dialysis or burn injury, patients with abdominal compartment syndrome, intestinal hyperperfusion following aortic dissection type E, A, or B, or we have colonic ischemia following repair of ruptured AAA. So the case of ruptured AAA, I will stick to that a little bit, because this is the it's a special area that be suspected of having NOMI, or we should suspect that this is possible after repair of ruptured AAA, and they of course at the intensive care unit. What about plasma biomarkers? Well, we have no good one. Increasing trend in plasma lactate, it is not a very good biomarker. What has come up in the latest guidelines of the European Society of Vascular Surgery this year is in patients with that has undergone repair of ruptured AAA and that it's suspected of having colonic ischemia or non-occlusive mesenteric ischemia, there is an indication, a recommendation to perform a flexible sigmoidoscopy in these patients, because 90% of those patients with NOMI will have an affected colon sigmoideum, and you will be able to diagnose that with the flexible sigmoidoscopy. So we go to some recommendation by the ESVS guidelines regarding NOMI. So in patients with known risk factors for intra-abdominal hypertension and abdominal compartment syndrome, as for instance, ruptured AAA repair, I believe that if you are treating those patients in your hospitals, I think it's worthwhile to monitor these patients with intra-abdominal pressure measurements and to be able to counteract this in time before they have NOMI, actually. And we do it like this in Sweden, I suppose. We have this transbladder measurement connected to the patient's urinary bladder system, so we can intermittently measure the pressure from within the abdomen in this way. And we have the guidelines from the World Society of the Abdominal Compartment Syndrome that defines the abdominal compartment syndrome. If you have an intra-abdominal pressure above 20 millimeters of mercury and you have new onset of organ failure, then these patients, for instance, if the patient has undergone a repair of a ruptured AAA, these patients should be brought back to the operation room and be decompressed to do as much as possible to save the patient's life, actually. So here are some tips. I have brought this forward because you are intensivist, and I think you might benefit from some of these tips, or think about it or be aware of it in your practice. So here are some of these tips. So measuring intra-abdominal pressure at the end of the operation for ruptured AAA, this has to be done by the surgeon, actually, and be prepared to perform decompressive laparotomy. After you're finished, you have the abdomen together. This can be done at the operation room already. And you can also have a collaboration with the anesthetist. And I mean, you should always have that, of course, but you should inquire what is the patient's peak and inspiratory pressure at the end of operation. So if it's difficult to ventilate the patient, if the patient have a end inspiratory pressure of about 25 centimeters of water or something like that, then I believe this patient has abdominal compartment syndrome. It's better to decompress the abdomen. And as I said earlier, you should include intra-abdominal pressure in protocols in the intensive care units for some patients. I believe it's of benefit. And for the surgeons, leave the abdomen open in patients undergoing open repair of ruptured AAA with concomitant intestinal ischemia. Sometimes it's present already at operation, primary operation. So I believe to maximize visual perfusion, you should leave the abdomen open. And we use the vacuum-assisted wound closure devices here. Leave the abdomen open in patients undergoing open repair of ruptured AAA where there is difficulties in closing the abdomen. Well, if the abdomen cannot be closed properly, you have to use a lot of force and so. Better leave it open then. So what about computed tomography? Well, it has arisen as an important tool, not only for diagnosing mesenteric venous thrombosis or mesenteric arterial occlusion, but also actually for NOMI, for non-occlusive mesenteric ischemia. And perform these CTs with intravenous contrast media. And remember that the more severe mesenteric ischemia, the more findings of intestinal abnormalities you will find. So here are some papers on the performance of CTs. And absence of bowel wall enhancement, that is a clear, consistent feature in patients with non-occlusive mesenteric ischemia. Another feature that is very important is if you can see pneumatosis intestinalis or gas in the portomesenteric venous system. These are clear features. These are features that indicate if the patient is at the intensive care unit and you are watching a patient with suspicion of NOMI and you perform a CT and you see these findings, you should call the surgeon on call and say, I think you better have a look in to that abdomen because we think this patient has transmural intestinal ischemia that only can be managed by bowel resection. So here are some features. You can see the small arrow pointing at gas in the mesenteric vein, and the large arrow is pointing at pneumatosis intestinalis, that is gas in the bowel wall, which is typical finding of acute mesenteric ischemia. Here are the same features, but now we have the transverse view. So the small arrows points at gas in the mesenteric veins. I mean, these bubbles should not be there. The bubbles should not be, at the large bowel here, at the large bowel. All this is gas in the bowel wall. So this indicates transmural gangrene of the colon here. And the large arrow here points at free gas of the abdomen, that has been a rupture of the bowel. And there's free gas and the bowel contents are pouring out. So these patients need absolutely an operation and bowel resection. There's no other way to rescue these patients. And here is also features of what I was talking about earlier, is that decreased bowel perfusion of the bowel wall. There is less contrast enhancement of the bowel wall in the right colon here compared to the left colon. And you can actually measure this, the radiologists measure this by using something that is called Hounsfield. They have an objective measurement of how much something is enhanced, actually. And here you have these features as well in the transverse, where you have decreased perfusion, decreased bowel wall enhancement of contrast, whether it's more normal here on the left colon. So when you perform a CT angiography, you can check whether the artery is patent or not. So if the artery is patent, this is NOMI. But sometimes there might be a stenosis of the superior mesenteric artery or the celiac trunk. And if you have the possibility to perform angiography, then you should treat this stenosis. If this patient is at the intensive care unit, this patient receives maximal treatment, not right? So if you have available angiography possibilities, then you should go ahead and dilate these stenosis to enhance perfusion of the mesentery and the mesenterial artery system. to be able to allow as much perfusion as possible to the intestines and the mesenteric organs. I mean, liver, gallbladder, and yeah. So this is a highly recommended to perform that. And also, if you have the catheter in place, if you have the possibilities to do an angiography, and you dilate stenosis, then also be aware of that you can infuse papaverine or any vasodilator you have. We use papaverine at our hospital, and it has been shown in this study, for instance, even if it is a retrospective study, it is a selection bias and so on. But nevertheless, if you have the possibilities to do that, you have a catheter placed in the superior mesenteric artery, you can infuse that with vasodilator, and we use papaverine, and we use a bolus dose for 80 milligrams as a bolus, and then you can give 30 to 60 milligrams per hour, and you can do that for as much as long as 3 days if necessary. I mean, the patient can be brought back with the catheter outside the groin, and you can have infusion at the intensive care unit, as you are very much used to these pumps. So if the patient has NOMI and there's a possibility to perform angiography and you have papaverine at home, if the patient has NOMI, this is a treatment option as well. You should optimize everything you can for these patients. So what more can be done for these patients? So supportive care. I mean, you're the specialist in this, and there are studies saying that you should, if you have a patient with non-occlusive mesenteric ischemia, you should think about your vasoconstrictor agents that you are using. If it is possible to, if you use two vasoconstrictors, perhaps it is enough with one, or perhaps you can change one to another less harmful or less vasoconstrictive agent. So this is something that you might find useful in your clinical practice, if it's possible. I understand that some of these patients are very ill. They require a lot of vasoinotropic drugs to keep them alive. But this is something I think this is something you master, of course, but this is something you should constantly be aware of. So here is, I think, my last slide, and in patients with NOMI, this is multifaceted, this is multidisciplinary, that you are in charge of those patients at the intensive care units, I think, and these patients should, if possible, taken to the operation room with the capacity for open and endovascular surgery, where angiography with stenting in case of a stenosis or an intraarterial administration of vasodilators, and/or laparotomy for bowel resection can be performed. The majority of patients with NOMI that has risk of fatal NOMI, they are the majority, almost, 95% worldwide are treated with bowel resection. And in that way, some of them will survive and some will not. But you should think of the other possibilities, and you should also think about this supportive care that you master. So I thank you for your attention, and well, back to you, Tapesh.
Thanks, sir. Thanks so much for a wonderful and illuminating talk. Can you please stop the share screen, sir?
Yes.
Right. So I request the audience to put up any questions. Meanwhile, sir, maybe I can just put up some questions for everybody's sake. So, sir, we have a lot of young students amongst us. So can you please tell the kind of clinical presentations that this disease can have? When should we suspect? The patient can be coming from outpatients, or sometimes they develop in the ICU. So what kind of clinical presentations can we expect, and when should we suspect acute mesenteric ischemia?
Well, it depends. I had some slides before because of the clinical scenarios, patients arriving at the emergency department. But I thought, well, you are intensivist, and I thought perhaps you are only interested in the intensivist view. But I will give an overview of these patients from the emergency department to the intensive care unit. Well, from the emergency department, patients, often elderly patients, in cases of occlusion of the superior mesenteric artery, arrives at the emergency department with severe abdominal pain. They are vomiting or have diarrhea is the most common picture. Some of them will have atrial fibrillation. And they are arriving with a lot of pain. And sometimes they arrive, there are three phases. And this is the first phase that I mentioned. Sometimes they arrive later and they have already gone into the second phase where the pain resides. They have less pain, they will have more distended abdomen, and you know the surgeon on call will be fooled or misleaded, and so he thinks, well, this patient does not have so much pain, this patient will be observed for a couple of hours, and we will get some painkillers, and we get some blood tests and so on. And then the patients will be in the nighttime, and then in the morning, the patients will have full peritonitis, more pain, will be severely deteriorated. That is a common picture clinically in patients with acute arterial mesenteric occlusion. And then we have the mesenteric venous thrombosis that is only 15% has. These patients are younger, may have a history of venous thromboembolism before, pulmonary embolism or deep venous thrombosis. They often, when you do an investigation of these patients, they will have some kind of thrombophilia. That is APC resistance, factor V laden mutation, something in their blood making them more prone to have mesenteric venous thrombosis. And then we have the NOMI patients. And the NOMI patient is something that often is associated with intensive care unit patients. These patients may have been operated or not have been operated. They have septic shock. They have been operated sometimes for, perforated diverticulitis with peritonitis, and they have multiple organ failure. And the patient is not improving, and the patient is not doing well, and the lactate is rising. And these patients should be very suspicious of having NOMI. And then we have the typical patients for vascular surgeons is the patients with ruptured AAA that undergoes repair of the AAA. You can go do open repair, you can do endovascular repair. It does not matter, but because 7% of these patients will have abdominal compartment syndrome. And these patients will develop, if they survive enough time, they will develop NOMI and infarction of their colon. And these patients have to be brought back to an operation room, and you have to decompress these patients urgently. So these are some of the patients that the different clinical scenarios. And in the intensive care unit, I know, you have a lot of patients with different diseases. And sometimes when the patient is not doing well, there's always this suspicion of, can the patient has non-occlusive mesenteric ischemia? And there we need better plasma biomarkers. But you should think of these possibilities of to perform the CT and CT angiography, and also question the radiologist. Are there intestinal abnormalities that is secondary to mesenteric ischemia? So I think this is promising. You know, the CT is better and better, is highly developed and high resolution CTs. So this is possibilities for you. And also, do not forget to measure intra-abdominal pressure in patients with, you know, that are at risk of abdominal compartment syndrome. So at least I think this is a practice that is commonly practiced in Sweden, at least. And so if this is something you use in India, I don't know, but I should recommend.
Right, sir. Thank you, sir. So as far as intra-abdominal pressure monitoring is concerned, it is not widely prevalent, but it is catching on, sir, as people are realizing more and more. So moving on, sir, about lactate. You know, textbooks and literature mention lactate and play a lot of importance on it, that it is generally elevated in acute mesenteric ischemia. So first, sir, is it D-lactate or L-lactate in this situation? And does it help, you know, because if the lactate is normal, you know, does it rule out acute mesenteric ischemia?
No. It's plasma lactate. Plasma lactate. So D-lactate is another biomarker, and it does not rule out mesenteric ischemia. It often misleads. It has misled a lot of surgeons throughout the time. I mean, a patient with acute abdomen and you suspect mesenteric ischemia and you have lactate and it's normal, the surgeon gets relaxed and the patient is at observation. Instead, the patient should be at performing a CT with suspicion of mesenteric ischemia, and then when the lactate is normal, then it's early time. So and when it's early time, this is good news for the vascular surgeon and to perform intestinal revascularization, for instance. So lactate, in textbooks, I mean, since the study by Lange in the 90s, because Lange in the 90s, his paper on lactate, he presented that they were patients with acute mesenteric ischemia, they have all elevated lactate. But all died. all patients in his study died. And this was because they were diagnosed very late. So lactate is a predictor of death, actually. So, and it's a very late marker. At the intensive care unit, if you have increase in lactate, you measure this very often, perhaps this could be of some use. But otherwise, when I talk to surgeons and emergency physicians, I say to them that you should not trust lactate. And also, what is the problem? I think at intensive care unit, when you measure lactate, you do it properly. You take blood gases. But, you know, at the emergency department, sometimes you take venous samples. You don't take arterial samples. And these venous samples, they are prone to measurements error due to stasis. And when you perform stasis of the arm, for instance, or you let the sample stay in the tube too long, then there will be falsely accumulation and distribution of lactate in your blood sample, and it will be falsely elevated. So this is not good. So there is a lot of issues about lactate, but I think the main message here is do not trust lactate. It is a late predictor of intestinal ischemia, and it is a predictor of death, actually.
So just talking about pain in acute mesenteric ischemia. So textbooks, you know, and literature mentions some patients may not have pain. So is that correct? Have you seen such patients, sir, who do not have pain, and any reason for this?
It is, but seldom. It is, but seldom. Some of these patients often have pain out of proportion. That means very much pain, but minimal abdominal findings when you explore their abdomen. Initially, they don't have peritonitis. So you think the surgeon will be fooled because the surgeon thinks, oh, peritonitis, if they have peritonitis, this is a acute abdomen, you have to do something and so on. But if the abdomen is bland and the patient apparently, you have no findings when you explore the abdomen, then you might get fooled. So in the second stage, the pain often goes to regression. Because the patient goes into the second phase, the patient will have more paralysis, more distended abdomen, but we will have less pain. And sometimes this less pain fools the surgeon as well. And sometimes this pain, as you said, in a very few percentage, the patients apparently has no pain. But I would say that, I mean, 90-95% will have pain, and it will not go away. It will stay there. So this is not the usual patient, not the typical patient.
Then just a final question, sir. You mentioned CT angiography is obviously the test of choice, and even if the creatinine is elevated, we should go ahead. But some patients that have moderately elevated creatinine, some may have chronic kidney disease, and the radiologist is often reluctant. So is there any place for MR angiography of the abdomen?
Well, it is a good question. It is a good question. If they have chronic renal impairment, this is, if you have good communication with your radiologist, I think you can talk to him. And sometimes you can optimize your CT. You can also reduce the contrast level. You can, tailor the CT by talking to the radiologist. If there is an available MR angiography, if this is available, at our place, we don't have 24 hours availability of MR angiography, but if it's daytime and if it's set up, the MR angio room is, I mean, if it's ready, perhaps it is better to do an MR angiography than performing a CT without contrast, without intravenous contrast, because patients with intravenous contrast, we have seen in studies, they are not diagnosed, and they will be perhaps never diagnosed until they die, or be diagnosed very late and they will die anyway. So an MR angiography is better than not doing a proper CT. But I think you should discuss with your radiologist the options available at your hospital.
Thank you, sir. Finally, sir, what is the role of trophic feeding, sir, in these patients? Trophic feedings.
Again?
Trophic feedings, sir. Feedings. Trophic, small volume feeding, sir. So where do we place them?
Small bowel feeding.
Yeah,
I mean,
small volume nasogastric feedings. So when should we start them? Where do we place them in these patients?
Yes. I think the patient has to be stable before you do it. The patient has to be stable. I think there has to be some proof of bowel movement before you start, actually, because these bowel anastomosis are at hazard the first days, and you must see that all parameters are going out at the right direction after the operation. So after they have some bowel movements and they are not vomiting and so on, and they have some discharge of stools, I think you can initiate with some fluids, yes. And I think after a couple of days, if they are stable, I mean, you should increase that afterwards. I think you should be afraid of that early in the phase, but then you should initiate it, and initiate it at intensive care unit. Yes.
Right, sir. So thanks so much, sir. Wonderful listening to you and learning about acute mesenteric ischemia has so much of our audience. So really, thank you, sir, for your time. Bye-bye, sir. Take care, sir. Thank you so much.
Thank you very much. Thank you.